head or tail of these views. Then in 2000 again Dr. Krishna Kumar gave me these pictures and taught me how to recognize this. But once I mastered this, you can just tilt the transducer from below upwards and you can have a rough idea what the baby suffers and you can plan what you want to do. So here as you can see the aorta which is posterior and to the right side, and you can understand the pulmonary artery which is little anterior and to the left side, and you call it when the right atrium opens through the right ventricle to the pulmonary artery, it is a ventriculo-arterial concordance, and LV opening to the aorta again it is ventriculo-arterial concordance. So regarding the great vessels, again you can have a single outflow, could be a truncal arteriosus, or it could be pulmonary atresia or aortic atresia, or it could be a double outflow when in addition to concordance or discordance you have a ambiguous, one side is concordant, the other side is discordant, you have a double outlet situation. It's very easy to identify the pulmonary artery. It usually dips posteriorly and immediately bifurcates. You see this mustache, you know it is the pulmonary artery. And aorta is also equally easy to identify. You can see the coronaries originating from it, but you will need the help of the color to identify the flow, and it is non-branching vessel. So now we need to look at the septa carefully. You can look at both atrial septa as well as ventricular septa. In the ventricular septa, you look for the inflow VST or an apical VST or an outflow VST or a muscular VST. You know you are taking the section from below upwards. Depending on the location, you can have a clear idea where the ventricular septal defect is. Similarly, look at the intra-atrial septum. Look for a primum AST or a secundum AST or a sinus venosus AST. At times you may be dealing with no septa, the common atrium or a single ventricle. Now having summarized the views and the segments, I have to introduce you to a few more other terms in relation to each other. One is the straddling of the atrioventricular valves. Whenever you have a ventricular septal defect, some of these chordopapillary structures of one ventricle can go into the other ventricle, and that phenomena is called straddling. So it is very simple. Unfortunately, semilunar valves don't have any chordopapillary structure, so there is no straddling. Only atrioventricular valves have this. Coming to overriding, both atrioventricular valves as well as the semilunar valves can override, but you need a hole close to these valves. So atrioventricular valves will override when there is an inflow VST. Similarly, the great vessels will override when there is an outflow VST. Whereas straddling can occur with any VSTs. Only thing you need a large chordopapillary structure to go through that hole. So, having told you what is straddling and I have to tell you what is great vessel relation, the D loop, whatever what you call as great malpost or transposed great vessel, and what do you call by the ventricular looping. So this is a picture of overriding. You can see this AV valve should have been connected to only this ventricle, but it overrides the VST to the other ventricle. And here in addition you have a chordopapillary structure going to the other ventricle. There is overriding as well as straddling. Now when you have a single atrioventricular valve orifice like this, you need to consider whether both the ventricles are equal. When you call it balanced. When one ventricle is small, less than 50% of the other ventricle, you categorically say it is an unbalanced ventricle. So I have introduced another term now, the balancing of the ventricles. And this is a beautiful three-dimensional picture of the overriding of the great vessels. Here you have an outflow VST as you can see. The aorta is overriding the VST, so it is getting blood flow both from the left ventricle as well as the right ventricle. And why it happened, you know, it is essentially because the Fallot's tetralogy. The essential embryologic anatomy was this monology where the infundibular septum deviated towards the headward as well as anteriorly instead of joining here and closing the VST. So it created this outflow VST, and as it moved towards here, it makes the aorta override the VST. And since it has gone this side, it produces the right ventricular outflow tract obstruction. And now since the right ventricle is pumping into the systemic body, the ventricular chamber is hypertrophic. The single fracture, the monology, created all the four aspects of the tetralogy. A beautiful 3D demonstration how it happens. Now, here is a picture of a double outlet of the right ventricle. The right ventricle is giving rise to both the aorta as well as the pulmonary arteries. You can see the right ventricle to the pulmonary artery is a concordant connection, right ventricle to the aorta is a discordant connection. Essentially, it is an ambiguous connection as it is. And now the next topic is the D and L looping of the ventricle. The most important pumping chamber of the heart is the left ventricle. It is a conical chamber and it pumps directly to a tube, the aorta, which is almost straight in structure. But the right atrium, right ventricle and the pulmonary artery goes and hugs the heart like the right hand. So this is what is called the D-looping. As you can see in this picture, the right atrium, the right ventricle and the pulmonary artery hugs the aorta and the left ventricle like this. So if you keep the thumb on the inflow and the fingers on the outflow, it hugs the LV and the aorta, and this is what you call as the D-loop. In corrected transposition, the exactly opposite happens, the right atrium, the right ventricle and the aorta, and this is how it hugs, and you call it L-loop. So if you take the image, the picture beautifully like this, you can see the right atrium, right ventricle going to the pulmonary artery, you know it is a D-loop, and if you see the other way, it is the L-loop. So what is this normally related great vessels? As you know, the aorta mitral continuity, there is no infundibulum on the left side. Whereas on the right side, you have the tricuspid valve, the right ventricle, the infundibulum and the pulmonary artery, and a spiral septum develops. So that the right ventricular outflow tract spirals around the aorta. So that the aorta goes from, the pulmonary artery goes from the right to left side as well as anteroposteriorly. And if you are demonstrating the crossing of the great vessels in the anteroposterior as well as the lateral direction, you know it is normally related great vessel. So this is what happens. If you take a cross section, you see a cup and saucer. The aorta is in the center and the RV outflow tract spirals around like this. This is in solitors and this is in inverses. It is normally related great vessels. If it doesn't do, and if the great vessels are parallel, it is malposed great vessels. When you have malposed, you can have either a D transposition when the aorta is on the right trends or D post aorta, and it can be an L transposition when it is the aorta is left-sided, the L post aorta. The transposition essentially means ventricular-arterial discordance. So having shown you all these things, I will just summarize. You start with the situs view, then show the hepatic vein draining to right atrium. If possible, it is a little difficult. Try to image the coronary sinus draining to the right atrium. The pulmonary veins and left atrial appendage is much more easy to image, as well as SVC opening to the right atrial appendage. Then go for the AV junction view, the left ventricular outflow view, as well as the right ventricular outflow view. And these are the 8 segments and the 8 views which I would recommend. And you may have to substantiate these pictures by the cross section as well as apical fourth chamber and suprasternal view, even though you may be able to identify the side of arch from subcostal window itself. But if you can doubt, you will have to go to the suprasternal window to show whether the aorta is on the right side or left side, because it's extremely important. If the aorta is on the right side, you cannot approach it from a left thoracotomy. So that is why you need to sequentially look at it and make sure that the aorta is on which side of the trachea, so that the surgeon is helped to decide what to do. And thank you so much for the patient listening, and I am ready for any questions.
Thank you, Dr. Shivshankar.
Any questions?
Are there any questions while we go to the next?
Is it even by mistake, can we see 2 circles, 2 short axis view, so that we can confuse that even by mistake of doing of the echocardiography, because this has been very difficult thing, because they say that when you see 2 circles, 2 eyes of the arm, one has to think of either D or LPGA.
Yeah, I agree with you, because
So many times what happens, we start seeing these 2 circles, but we know that it is not PGA. But can we see 2 circles normally by the mistake of the person who is performing the?
it's a very, very good question, because this happens when you start your career, how you generate the pictures. But over and above, we try to standardize these views and show it properly, because because you can look at any, especially if you are going from the parasternal region, you have got a wide area to slide, and generate some pictures. You may be generating off-axis pictures. But from the subcostal window, or if you are going with the standard planes, we are able to see that you are generating either a long axis or a short axis perpendicular sex. You will not be able to generate two circles together. Especially those of us who do fetal echo, you can imagine and create anything you want. That is why nowadays we try to go by standard views and standard pictures so that another person who sees the picture can interpret. But by mistake, if you generate two circles together, but still you go for the standard views and look at their relation, and if you can convince yourself that the aorta and pulmonary artery on the right side, you may not have to commit that this is this or that. And I agree, it is only imaging, you can generate a lot of confusion.
The other thing which people very often ask, in the parasternal long axis view, if you see a vessel which is dipping down, going down, posteriorly, that could be again transposition because people go through the PA. The LVOT, you expect the LV and the aorta to go, come up and maybe go a little up. And if it dips down, people say it could be PA. But then again, Shivashankan said it could be really for big time trouble. So this is just one view. And it may not be true. Maybe there's a little bit of an anatomical way, the way you have cut. Maybe a particular patient may not have the window. You may have struggled to get that particular window. You end up making the mistake. I think the fundamental thing is to go through the segmental approach. That is the alphabet of pediatric technique. And then the chance that there's a test. But usual two clues which people give for transposition in quick this thing is parasternal short axis. Instead of seeing the circle and sausage, you see two circles or one circle above the other. The upper, the superior one could be higher, but it's not so.
We'll now go into our hands-on demonstration. We have a young gentleman here who has kindly agreed to serve as our patient for the hands-on demonstration. And what we've just shown you in talks, we'll actually show you by demonstration. And then when we go into the hands-on section immediately after that, you'll have a chance to practice this as you wish to show.
Oh, I see. Malayali.
How many of you predominantly do adult technos or practice in adult? Yeah, the trouble is in an adult with a congenital heart disease. Sometimes you can have a lot of trouble because you may not get to like an ASD, for example. You can be into I think that is one doubt or question which many people ask. If you have a big child or adult.
And this will be a big focus on the hands-on training, is really working on the subcostal window so you become an expert.
Most of the people do not understand the subcostal window. But even in an adult patient, you can actually have a basic segmental approach. You can identify the abdominal sizes correctly. And actually with a little bit of pill and moving the probe here and there, maybe using the liver. One who use the liver as a sort of an echo, friendly structure. The liver is really echogenic. If you actually use the liver and then scan through the liver, you can actually even get to the heart and get this. Some of the fine things like appendages, etc. could be difficult. But on most occasions, you will be able to identify the key segments like the abdominal cycles, then the atrial segment, the AV valves, the ventricles, and most of the time we can reach the LVOT. In an adult, reaching till the RVOT in the subcostal would be difficult, but you will have a fair idea. So I think older patients.
Now this is the first view take. You are taking the transverse section of the body at fixed sternum. You can see, identify the liver by its bright echo texture. You can see the, oh, it's not come there. There is something. Very good. Okay, now I am trying to take a section of the body exactly transversely. This is the right side and this is the left side. I have kept the marker towards the left, so I know there is the left side. And on the left side, I see the single circular structure pulsating very well. On the right side, I am seeing the winging inferior vena cava. And this is the vertebral column. This is the liver, as you can see by the echo texture. And this should be the side of the gastric air bubble. I have not worked for that. So now I know here it is the situs solitus, and as I just tilt the transducer up, I clearly see the cardiac apex to the left side. So it is clearly situs solitus levocoid. Having done that, before going to the further sections, I might just align the Doppler. Okay, align the Doppler to show the aortic pulsations. No, it should be aligned this way. No, come this way. So here, if you are really lucky, you can even see how beautiful the aortic pulsations are. You may look so. It is extremely important to understand this because you can understand a variety of other abnormalities. If you see a slight reversal like this in diastole, you will notice mechanical. Okay, it is the chemical. Here, if you see a reversal, think twice. You may be dealing with a small aortic regurgitation or a PDA or something is this. That gives you the clue. Similarly, if you see pulses alternate, so you may just, the diagnosis clear. Every alternating pulse, you have got different. Well, you know you are dealing with an LV dysfunction. And similarly, if you are showing a large respiratory variation, you know you are dealing with the pulses paradox. If you see beat to beat variation, you know it is atrial fibrillation or going to deal with the complete heart. So even though it doesn't look that simple, it gives a lot of beautiful information. And in coarctation, there will be diastolic tailing. So you don't have to go and search for the aorta. The simple pulsation has given you the information you need. So now look carefully. Here again, if I am tilting to the left and seeing the aorta, I know it is a left-sided arch. And if I am tilting to the right side and getting the arch in that direction, I know it is a right-sided arch. So that information also can be got from this view. And here I am seeing the IVC and hepatic veins opening beautifully. I can see the IVC is collapsed, the systemic venous is not increased. And here it will be better to put the pulse Doppler in the hepatic veins because that will be the best aligned than the other structures, and you see the hepatic venous pulsations coming. So I think that is simple for all of you. I am not going to elaborate on that. Having done that, I will take away the color. I will go to the next first window. Can you get the picture in front? Okay, very good. Now I am going to show the first picture which you have to do where the IVC opens into the right atrium. So these are the hepatic veins, as you can see. Just confirm it by a color also, and look at it how where it opens, and you can nicely see it opening into. Can you put a good picture? Color. Okay. Now you can clearly see the opening as well. This is one good thing you can do. You put a color compare. You can see both the structures. Or I didn't talk also. I wanted to to come. Okay. I can see both the hepatic veins opening. Can you see that? As well as I know that structure is the right one. Now slowly look for the junction here, the atrioventricular structure that opens there. You can see here is the coronary sinus. Normally it is small, so you will see only a red color flipping into the right atrium there because flow towards the transducer is red. And now you can see both the coronary sinus as well as the intraatrial sinus. Having seen that, take the color, make the color a bit smaller. Now you can see beautifully the pulmonary veins almost like opening like a Y into the right atrium. Can you appreciate that? Both right-sided as well as left-sided. This is the left-sided pulmonary veins. So this is the left-sided pulmonary veins and these are the right-sided pulmonary veins. You can see the color flow almost like a Y in real action as you can see. You can see that. And now I tilt it little more upwards. I can understand the SVC opening into the right atrium, and by the side of it will be the right atrial appendage. Right atrial appendage will be seen almost by the side.